So that's when the Dr. Leonard McCoy says, my God, Jim, we can't leave him in the hands of 20th century medicine. That is what we are today. These butchers will use needles and knives and cut open the belly and chest. It's still the dark ages. You have no idea what those barbarians can do. And this particular thing really stuck in my brain. That's when I used to think a lot about how to make it much more easier and simpler without cutting open. So what exactly is laparoscopy? It is nothing but the same surgery what you do in open in a smaller holes. The surgery inside is the same. The incision transformed from vertical to transverse to smaller incisions depending on where we need to do what to do. This MIS started and led to a revolution in the modern surgery 4 decades ago. But still today, we are still talking about can it be done? Will it be done? Even today morning, we had a patient who said, I had 4 previous surgeries, 5 surgeries. Can I get it done? Somebody said it has to be only open. So I think it is definitely not the machine which is important. It's the man behind the machine, and how good the training is what is very, very important. Currently, it is a standard of care for many surgical interventions, and patients often seek out for the surgeons with special training in MIS. But what we need to understand is laparoscopy is a double-edged knife, and it is an opportunity for promise and abuse. So key aspect for any understanding of any new technique we take is a solid foundation which is grounded in the scientific literature. It's both the technique and technology which go parallelly. That is what we need to know. It's not just the technique which is going to give the better outcome, but the technology which comes and upgrade ourselves in each technology which comes in the way of our journey of getting trained. So these are all the things which are important. Sorry, this has to go down. Yeah. And so when it comes to laparoscopy, especially in gynae, it is not evidence-based because we don't have RCTs which say that this many open, this many lap, this is what it has done, because science keeps changing from human being to human being. And in our cells itself, 5 fingers are totally different. So most of the time it is experience-based, and we get trained by looking at the doctors who are doing the surgery, plus hands-on training, plus the wet labs, plus the simulation, what all we have to do. So it is both the scientific knowledge compounded by the training which we have, and the recurrent repeated training which we all go in the ongoing journey of the surgery is what is important. So evolution and evaluation is not as scientific. We are not trained for 3 years like we do in the post-graduation, and never is a surgeon equally well trained to perform both, that is open as well as endoscopic surgeries. So it is our enthusiasm for these new technique which took us to where we are. So we have our minds made up about what we want to do, and we shall do what we have to do. So today I want to tell you all how safer it is. There are only 2 laws or 2 rules of laparoscopy, that is safety of the patient and the comfort of the surgeon. So most widely used gynecological procedure right now is the laparoscopy. And in 1988, it used to be completely by gynecologists, but after that, it was this general surgeon who took over. We hardly see anybody doing appendicectomy or cholecystectomy without laparoscopy. So that is the day we have to do that. Any hysterectomy, any size, any type, any complication, any cell should be done by laparoscopy. This is what we need to understand in today's time. So we worldwide seek to use minimal invasive surgery whenever possible, therefore reducing the number of abdominal surgeries which has to be done. Why are we rushing? Because we do know all these are something which are there. Less disruptive, generally recover faster, less pain, fewer wound problems, and less scarring. But for us, what is it? It is a precision, the dexterity, and the flexibility which comes with those things. So, but except for abortion, I think hysterectomy, and especially the myomectomy, created more controversy and discussion than any type of gynecological surgery, especially because of the modulator which has been used. So let me take you all stepwise through introduction, guidelines, why LapRoot, surgical technique stepwise so that we can make it a safe surgical technique, clinical decision-making, and how do we avoid complications and conclusions. Worldwide, the numbers are the same. 40% are done for fibroids, AUB that is, 17% for endometriosis, only 15% for prolapse. Again, worldwide, still today, it is abdominal in 60 to 65%, vaginal in 20 to 25%. Laparoscopy still is the last, around 10 to 15%. We need to, time has come for us to just change the whole thing. Nowadays, we do have robotic. When I say MIS, it is both robotic and laparoscopy. And we do have V nodes also, which we need to understand. Whenever we think of hysterectomy, we take certain factors into consideration to know what is the best route. 1, how is the vagina? Is it the nulliparous or very, very postmenopausal with this very inaccessible size of the vagina, or the uterine size and shape, and is that vagina accessible for that particular uterus? Then the mobility of the uterus and surgeon experience and training comes first. If I'm trained in laparoscopy, I would like to do without a size in laparoscopy. And the same thing appears good for the surgeons who are trained in different techniques. The extent of the disease, is it frozen pelvis or previous cesareans causing the whole additions? An informed patient preference. Why did I use this sentence? Because a patient is stuck in the brain that I do not want laparoscopy. She will never be happy by convincing her than doing laparoscopy. And the patient wants laparoscopy, please do it in laparoscopy. And another thing, what is important is the available hospital technology, devices, and support. Don't ever compromise with the technology. What we see is very important, then only we can operate. So advanced technology and what we see and the energy sources are two things which we cannot compromise with, because lateral thermal damage causes the complications, which once we get demoralizes us and does not help us to move on in future. So let me take you all to understand what are the recommendations by ACOG or FOSSI or whatever. So they all say that well-documented advantages and the lower complication rates with vaginal. So whenever possible, it has to be vaginal. But otherwise, then the laparoscopy, the last will be the abdominal. Saying that robo or this thing is definitely better in today's time than even vaginal, because there is only one study which said that they compared and said main outcome definitely shorter with laparoscopy. Secondary outcomes are comparable. Conclusion is that vaginal hysterectomy is not necessarily superior. So whatever technique you master, recurrent, repeated uses, that is what we go into. Advances in both techniques and technologies often emerge together. This has led us to understand that lap route is the best, and we have done. And there are certain cases where insurances have come forward and said, if done in certain type of schemes, it said, if done in laparoscopy, that's where it is better to do. Go ahead with laparoscopy. The insurance will be covering it. Otherwise, it will not be covering it. That's when everybody started learning it. It took us almost a decade from 1990s when we started till 2006. Nobody showed interest in learning because of the learning curve being high. But after that, the new generation came up. We started thinking this is the new norm, and they want to learn, and they are learning. In today's time, almost every indication for hysterectomy can be done with laparoscope, and very few reasons are there for any expert laparoscopic or vaginal surgeon to do this. Therefore, open surgery should be a fallback technique, and it should never be do that thing. Again, why lap route? Patient awareness has increased. And what is arrogatory? Arrogatory was a scheme which was given by our government in Andhra Pradesh in that time. So where they said they will only cover, and the money will be given to the hospital if it is done by laparoscopy. That improved a surge of surgeons trying to learn laparoscopy, and the learning curves came down. So whatever schemes helps in whatever technique people have to learn, that helps the outcome for the best of the patient outcomes. Patient awareness, that led to a lot of awareness of patients in the form of outcomes. So once the outcomes were increased, and that's where the patient understood that, okay, my neighbor got it done and they had a better outcome, so let me undergo the surgery in that. As and when we started doing more and more, safe techniques evolved. Training facilities have improved, because it's like you need something and you get it. So you are there. It is you have a consumer. That's when the training facilities also improve, and the decreasing learning curves also happen. So that's how the whole thing happened, and the laparoscopic revolution has evolved. Then the technology has evolved. The creation of pneumoperitoneum has evolved right from the time when we used to use cycle pumps to the time when CO2 comes through the pneumoperitoneum is created. Pneumoperitoneum techniques itself, the ports from varies to the open to the VC ports have increased. The rod technique, which I'm going to show you all. Fiber optic scopes and video system has evolved. Light source have changed from the incandescent light to LED, where we are right now, through to the complete fiber optic light source. The trocars, like I said, from the metal trocars to the VC ports, we have evolved a long way. Hemostats have come, which can be decreasing the local hemostats, for thrombin-forming hemostats, which decreases the local bleeding, to the energy sources from unipolar, bipolar, advanced bipolar, to the harmonics, what we have. So we need to understand and learn the energy sources and then know how to use it so the complication rates can come down. The instruments have miniaturized right now from 10 equipment to 5 to even 3 depending on the case. Other ancillary equipment like irrigation techniques, in corona times, how to divert the carbon dioxide. So many equipment has evolved as and when necessary, morcellator and everything. So this slide, I'm going to stop a minute to make you all understand certain things and then go. What is the role of catheterization? The questions come, do we have to do it? Can the patient just pass the urine before the surgery and come off so that we don't have to worry about the UTIs? No, we do have to catheterize the patient for that during the surgery. When do we remove it? Just after the surgery. For the surgery, why do we need it? One, to keep the bladder compressed. We do not want it to be distended. Second, whenever needed, the bladder walls can be distended so that we understand it. Third, by keeping a urobag and not a urometer, whenever the carbon dioxide is leaked because of some breach in the muscle of the bladder, the urobag just distends. So then then we can go searching for where the injury is. And fourth, the input output is needed, very much needed when the anesthesia and the surgery is going on. So for these reasons, we need a catheter with a urobag and which we remove it after the surgery is done. Bowel prep. Do we need a bowel prep? See, what is needed now with a lot of RCTs coming up that it doesn't make any outcome effect. What we need is that clear liquid diet 1 day prior to the surgery and NBM from 10 o'clock in the previous night. This is what we do it. We do not give any proctoclase or electrolyte enemas where electrolyte imbalances happen to the patient and the patient becomes dehydrated, which we do not want. And when it comes to the nitrous oxide, and remember one more thing, any enemas or Delclax suppository which cause bowel loop distension, and that comes in the way of the surgery when we do the surgery. And nitrous oxide in anesthesia is absolute no-no because it causes intraoperative bowel loop distension. Sorry for that. When it comes to port placement, see, we have a primary ports, we have secondary ports. Primary ports can be intraumbilical, infraumbilical, supraumbilical, Ziphister, that is epigastric, or right palmar, left palmar, or Newton's point, or Li Huang's point. Now, when we look at all this, primary port, what is the function? That is the only blind port where we enter into the abdominal cavity. Rest of the ports are all done under vision, so we can avoid all the injury. So what we need to know, the minimum distance between the pathology and the primary port should be 4 to 5 centimeters away. The thinnest point is an umbilicus, but the infection rates will be little high. So we go just supraumbilical, which gives us 1 centimeter extra space. And also, I can give my technician will be away, or the laparoscopic scope person assistant can be away from me on the not breathing down my neck. And in today's time with the transverse spinal steel incisions, all the additions are below umbilicus and never above the umbilicus. So I can avoid the additions. Then blind entry will be lesser chances. And also we can have the upward displacement as air. So the entrapment of carbon dioxide under the diaphragm will be lesser, and my technician will not be breathing down the leg. And other ports, depending on the height of the uterus, if the uterus is 28 week size, epigastric port. If the chance of additions are very high, then go to right palmar or left palmar. Most of the people are used to left palmar because stomach can be decompressed. But I am used to right palmar because never does the liver come below the intercostal line. So 2 centimeters below the intercostal line, along the mid-clavicular line is the point we give the palmar point. And the right palmar helps me in my technician being on the opposite side. So again, they don't breathe down the neck. So then comes the secondary port, and we are all the ipsilateral surgeons, women, ladies. For the ergonomics, what is very important is the shoulders, and we just have to do the surgery, what we do in the open, we just have to replicate what we do in the laparoscope. So when we are doing that, that means our shoulders should be in the place where it has to be. It has to be the hand movements, fulcrum should be at the level of the anti-abdominal wall. Hand movement are the ones which keep moving. So that is what is very important. So ergonomics are important. So left lateral ports are what the ipsilateral ports which we use. When we are using left lateral ports, I will show you in the video how we put them. Then coming to 30 degrees and 0 degree, when you want to do advanced laparoscopic surgery, always 30 degrees, because uterus is never end-on organ. It is sloped, bladder is anterior, bowel is posterior. So when it comes to energy sources, yes, like I said, if you want to do only simpler procedure, unipolar, bipolar, but if you want to do advanced, it is always unipolar, bipolar, and advanced bipolar or harmonic ultrasonics is what you would say. For minor surgeries, it is hospital stays, daycare. We do in the morning and they go in the evening. But if it's advanced surgeries, it has to be patient happy. We usually keep them for overnight. They can still go morning to evening, but we keep them overnight so that overnight so that they pass the urine and the motion and then they can go. So we'll be very happy when they pass the urine and the stools. Eating after surgery, within 4 to 5, 6 hours, we start the liquid diet, then the normal diet will follow. Usually the first day night, we just give them soups or ice cream or jelly or something like that so that the nausea vomiting comes down, and the next day is a normal diet. There's no role of absolute red. Within 4 hours, the patient is ambulated and then shifted to the room and back to work. Maximum is 1 week. So let me repeat what I said. Catheterization, feeding tube or Foley for 4 to 6 hours. Bowel preparation, patients should be on clear liquids 24 hours prior to the surgery, and NBM from 8 to 10 hours prior. No enemas, no laxatives. We don't want bowel wall distension. Nitrous oxide in anesthesia, absolute no. 30 degrees or 0 degree in pelvic surgery, only 30 degrees. Energy sources, monopolar and bipolar, and vessel sealers or harmonics if advanced procedures are done. Hospital stay, minimum is 4 to 6 hours. Anesthesia recovery time for basic procedures. Advanced, we keep them for 24 hours. Eating after surgery, 4 to 6 hours, liquid diet followed by normal. Absolute rest, no role, back to work within 24 hours for basic, maximum a week for advanced. So again, one slide where I'm going to hold on for a minute before I go into the operative technique. First, cervix health. We just use a regular uterine elevator. We do not use any manipulator, but anybody can use whatever they want. Then we put in the sports and then scope and ancillary reports, which we are going to see in the technique. One's first step is always the 3 ligaments of the uterus, which I say that is the upper ligament, that is round ligament, ovarian ligament, and the fallopian tube are clamped, were coagulated, and then cut. Then the immediately, like in open UV fold of peritoneum is removed, then broad ligament is separated, then the uterines, then the vault, then inspection thing. So let me go with everything. So first step is the primary entry. This is the Anagani technique of entry, which is a immediate supraumbilical. We give a frown shape 1 centimeter incision till the rectus sheath. We open using the knife. Once the rectus sheath is opened, using a curved artery, we touch the peritoneum and enter into the abdominal cavity. Once that little opening is done, the conical shaped rod is, the customized rod is there, which is put through the port and through the trocar, and the rod is inserted into the abdominal cavity, and the port is then, the riding of the port is done over this. You can see the ease with which the port can go inside, no ergonomic damage or no thrust onto the shoulders. So once the gas, so one open technique or closed technique. This is an open technique where modified technique, that is, there is no injury to the open definite entry, no injury to any organs inside because it's a blunt conical end, and no ergonomic damage. Left lower under vision, it has to be avoiding the inferior epigastric, and upper avoiding the superior epigastric. So how do we do it? It has to be as lateral as possible under vision, and 2 centimeter usually above the bony promontory of the iliac fossa, but that should not be the main thing. Never too close to the bone, below 2 centimeter above, and as lateral as possible. And when it comes to the upper port, we make it lateral to the rectus muscle, because the superior epigastric is in the posterior layer of rectus sheath. So once we go lateral, we are avoiding the thing. The third port which we put is in the suprapubic port under vision, where we use it as a uterine manipulator. So now we are inside. Let me show you what happens. Left lower is what it is. The suprapubic port, we use a myoma spiral, which goes in between both round ligaments. Now, I don't have any uterine elevator or anything. I don't use anything. You can see the bowel loops, which are well nicely collapsed. Now, the first 3 I said, first is the round ligament, ovarian ligament, and the fallopian tube, which are coagulated. And then I use all energy sources. bipolar to coagulate. And what we need to understand is how to make our bipolar into advanced bipolar. We use the pulse technique, that is 1 to 3 stop, 1 to 3 stop, so that lateral thermal damage does not happen. So first, the 3 ligaments of the right, I will repeat it. The 3 ligaments on to the right and the left, both are coagulated and cut by using bipolar, by compression and pressing the foot pedal. 1 to 3 stop, 1 to 3 stop, 1 to 3 stop. This is the way we go forward and then cut the 3 ligaments. So this is what we do for the upper 3 ligaments and cut it. Adnexia is always in the last. I will tell you why. We do not want these things hanging around when we are doing hysterectomy. And when we do it in the last and we pull it above, we can avoid the injury to the ureter at the level of the pelvic brain. Next step, once we do it, the next step would be UV fold immediately. So anteriorly, there we can do a central window technique or lateral window technique. I prefer central window technique. This is the unipolar energy which I'm using. We can use ultrasonic. You can see the spatula, which is my favorite instrument, which I'm using, and that is touching the anterior-uterine wall next. I'm never allowing the hot spatula to do that. You can see the blood vessel which is seen through it. So you can master the precision with which you use the energy sources. So there's a vaginal tube which is in the vagina, which is pushing the uterus cephalad, and the UV fold is being pushed. So initially, when you are learning, there's a new technique, which is a small technique, which I'll tell you all how to use it, how to push the UV fold for the proprioception. Put in a gauze piece inside. Once you do the UV fold, use that gauze piece for the proprioception over the vaginal tube, which is there. So that way, you will have a proprioception of feel till you master the technique of learning the proprioception through the instrument. So that's the way you push the bladder down and the bladder pillars also whenever necessary. So lateral window technique is going from the lateral, which is done for previous cesareans, which I will show you how to do it. Central, I prefer central because the natural forces of the anti-abdominal wall just pulls the bladder away, so that the safety margin is much more better. So once we do it, the bladder is being pushed down. The ureters are more lateralized. You can see laterally how the UV fold is taking the thing. Now you have the uterus here, and ureter will be lateralized by doing this technique. So next, in the previous cesareans, there will be 2 types. They look very deceptively like this, but centrally, again, they're stuck to the lower uterine segment. In these cases, I still again prefer the central window technique. But here, like a blade, we have to use it onto the lower uterine segment and cut it so that the bladder just pulls away by the natural forces of the anti-abdominal wall. So the adhesion to the lower uterine segment is something which will take the UV fold slowly down, but use it like a knife. How do you use it in a open technique? You just have to replicate that. So when you're using harmonic for a previous cesarean, it's always harmonic, never a unipolar, and that. So when you're using harmonic, which we use, the inactive probe goes inside an active probe. You can see that the way we are using like a knife. So it cuts and backscores, and you use in the high power only cutting mode and not a coagulation mode. When it comes to when we have to cut, never use current. We go. These are the type of surgeries you all have to get used to now. The whole bladder will be stuck till that. The uterus is stuck to the fundus. So how do you do these cases? You need to understand that fat does not belong to uterus. You can err a little bit onto the uterus. So you start from here, start from the central, go there, but find the round ligament and go through the lateral window technique. Start from the round ligament, go lateralize it, and then forget about the center. I use a harmonic a lot for the back scoring, and then go and create a window between anti-abdominal wall and the lateral broad ligament, and then slowly come over and then separate from the bladder. See the window which we are creating here, and then through that slowly separate it from the lowest point of adhesion. You can see there it is the window which we start. Retrograde dissection is what is important. Create a window, then cut it from the fundus. So once that is done, then separate. You can see that cephalad push is being done by the vaginal tube, and again open in the other way, then put a myoma spiral at that time, and the cephalad push is now amplified by using the myoma spiral. Here, that is a lateral again window we are creating in between. Lateral window technique and retrograde, that's the bladder which is adherent at that point. Then separate the whole thing in the retrogradely. There, you open it. So path just opens if you really go in the right way in the lateral window, which is where the bladder is not adherent. So come from the place where bladder is not adherent to the place bladder is adherent. So the novice place to the adherent place is the way to go forward, and cut it like a thing. And now you can see how neatly the whole bladder came down. The vaginal tube can now be seen there in the center. Whatever is left over is being pushed. And now you can appreciate the vaginal tube there and the bladder completely pushed on. So first, no panic reaction. Second, come from the innocent area or not adherent area to the area which is there. So we start from the lateral windows both and come into the center, or come from one lateral window, go in the retrograde fashion, create a window there and then open it, or start from central, try to open it. If it is densely stuck, change over to the lateral window. So anything is right. Like I said, there's no right or wrong. It is either it has to be the safe technique. So what is important is safety of the patient and comfort of the surgeon. Next comes, once you have done the anterior and then broad ligament is separated, anterior posterior, comes the uterine. Do we have to skeletonize? There are many people who try to tell you all that but this is my technique where we do not skeletonize. So we just have to, we need a lot of coagulum to form. So use it. Pulse technique, 1, 2, 3. 1, 2, 3, like you can appreciate that when you do pulse technique, lateral thermal damage is less. So push the bladder always down, then 1, 2, 3, 1, 2, 3, 1, 2, 3. Then I use the harmonic to cut it. Scoop out technique. What I use for uterine is scooping out technique. We scoop it out from the uterus so that the uterine just pulls it away again laterally. So the whole uterine comes away without getting multiple injuries to it. And we have a clear-cut area between the uterine and the uterus, and we can cut it through that. So this is the technique we use, that is scoop out technique. But there are people who skeletonize. The coagulum which forms when it is skeletonized is very weak, and the chance of uterines opening up later because of the burst pressure is very high. What is burst pressure? Burst pressure is pressure at which the uterine arteries any vessel just opens up. So later if the pressure increases, this is the way it is going to be. And for any coagulum to form, you need protein and water, that is intracellular liquid. Now, can we just, I will show you another thing. Do the suture? Fine, as long as you're confident, do the suture. But we don't want this to happen like this. I'll show you this video. 1 second, please. Yes, I think this is getting stuck with it. Okay, so this is a case where it was suture was done, and after some time it starts pumping. So then there is I'm sorry, this is not playing here in this. Anyway, so what happens in this is that then in a panic, you start burning it in the lateral pelvic wall. You anyway have to do a coagulum, do it and then cut it. And if you have to do a recoagulation, hold the pedicle, pull it upwards and medially, and then only you'd have to do it. Okay. Now, finally, what comes? Lateral Macon-Rods and vault. Vault, I always do it from the posterior because bowel loops, I don't want them falling. You can see the uterosacral here and the broad ligament posteriorly. So we cut the broad ligament, which was not done before now. And then in the center, I call it a cervical girdle. And this girdle is being delineated like this. So once it is delineated, we cut it on the vaginal manipulator, which is there. It's a bivalve manipulator, which I use initially, and then go to round one, which is there. And whenever you use a unipolar to cut, you use a unipolar to cut means cut. You can use an ultrasonic also. You put immediately cold irrigant fluid so that the temperature there comes down. With the unipolar energy can go up to 400 degrees centigrade too. So once we put a cold irrigant fluid, the temperature comes down. So then when we go anteriorly, the bubble loop falling there will not get coagulated. So again, once the anterior is done, then posterior colpotomy. Anybody who wants to go in for an LAVH can do this step before even uterines and then start doing from below. Anterior colpotomy, posterior colpotomy, and then put a speculum from below, speculum from above, and do 1 or 2 steps here. So we saw that, and Macken rods being done, and then the whole vault will be cut then. So anterior colpotomy, posterior colpotomy, then the Macken rods, and then the total colpotomy. This is the way we go ahead and do it. At the end of it, do we suture from below or above? That's your choice as you go about. So let me first show one after one. Like I said, adnexia is always at the last. Why? We can just pull the adnexia medially. So we get about 5 to 6 centimeter space between the ureter, which is stuck to the lateral pelvic brim and lateral pelvic wall. So once the ureter is still there, your lateral thermal damage is not going to do. So by doing a UV fold first and pushing the bladder down, we are decreasing the chance of ureteric damage at the level of the uterine and the vault. Second, by doing a scooping technique, we are avoiding the damage to the at the level of the uterine, and also by pulse technique. Third, at the level, by doing again scooping and pushing it down and using a cervical girdle technique, you're avoiding the damage at the level of the vault. By using the adnexia at the last, by holding it and pulling it medially, we are doing preventing the damage to the lateral pelvic wall ureter there. So this is the way we do it. Now let me show you at the end, if it is done from below or above, we just have to definitely have a look. This is the major advantage which we have with these things, because we are just doing a vision under vision. Any small bleeder at the end of it, we can still keep it under control. So now let me take you all through the surgery again in a nutshell. So suprapubic, left lateral, and left lateral. Then myoma spiral between the two things, and you can see the way it can be done. So pulse technique, 1 to 3, 1 to 3, 1 to 3. When we do it, lateral thermal damage is hardly there. Do not forget the Simpson vessel, which will be there. That is the most nagging blood vessel which will be seen there. So look at the uterine, which is visualized there. So the 3 things, that is fallopian tube, ovarian ligament, and the round ligament is being done. Unless the round ligament is cut, the mobility of the uterus will not be good. So we do the first 3 ligaments first on bilateral. I do not believe in doing one side and coming for the other side. We do both the sides. Then immediately, this is a central technique. You're using it like a knife, and you can see the way the whole UV fold pulls the whole thing down, and the uterines are lateralized. You can see the pubocervical here, that will be cut. So the one which is nearer now automatically is being pushed on to 2-3 centimeter down. So now posterior broad ligament layer is being separated, and that is the uterosacral which is there. So till the cervical girdle we come. Do not cut the completely uterosacral, it has to be adherent to the cervical girdle. So anterior UV fold, posterior broad ligament. By doing this, you can see the 1 centimeter lateralization of the ureter, which is automatically happening. That is the uterine which is there, for which she was bleeding so badly. So now again, pulse technique, only in the loose areolar tissue in between the lateral wall and the uterine. There. Then coagulation and cut. There. Now comes the uterine scooping out technique. You can see the way my hand will be rotating. By doing the scooping out technique, you can see the clear cut space between the uterine and the uterus. So you will never encounter even a descending cervical in that. So this is the pubocervical which was there. So now that is being pushed down. Then the scooping out technique of that. And once that is done, posterior colpotomy is being done. You can see the uterine on the right side, which is completely lateralized because of the scooping out technique. Cool irrigant fluid. You can see the uterine jutting out. You can see the uterosacrals, bladder being pushed down at every step. and cutting. See that bladder is being pushed down at every step, and cutting current using is going to cut the vault. Now pull again fluid again. Then comes the Macken rods and the vault in toto. There, the complete colpotomy being done. Once it is done, especially in postmenopausal, be sure the whole of the cervix is being completely cut. Check for the ureter. See, you can see, this is to just show you all how lateralized the ureter will be. That white thing which is going there is the ureter. There you can see the peristalsis. Here, adnexia, again to the last, here it is only BS. Next comes the suturing. Suturing can be done using the barb sutures or the 2 figure of 8. I prefer 2 figure of 8, but in this video, I think we have shown the barb suture, how to go about. Now check the whole cervix is intact. Here's a perimenopausal AUP case. Now, avoid the angle. That's the first principle. Go through the uterosacral and then go anterior. Never go to the angle. You don't need to suture the angle. You try and you can see it very clearly how it is lateralized. So this is a V-lock suture with an eye in the end. So we are using a barbed suture here in this case. There, the uterine is lateralized, and then through the center, we just go there. It can be a figure of 8. It can be a barbed suture, what we use. Never involve the angle. Go from one uterosacral to the other uterosacral. Come back if necessary because it is a thing, and then cut it. I prefer a figure of 8 and even opening in the center in between because any small collections can go out. So at the end, always visualize. With barb sutures, you don't have to be worried about knotting. So this is the way the surgery looks. Blood loss will be hardly 5 to 10 ml. So what are the contraindications? When I say anybody can do, yes, anybody can do, any good surgeon can be doing it, but get yourself properly trained. So contraindications will be inexperienced or inadequately trained surgeon. Second, if anesthetist says, I will not give GA, please do it. Any other technique, vaginal or anything, because I feel that doing under spinal laparoscopy is a real inhuman thing. Doubtful pelvic mass, especially ovaries, are very dangerous. So I think you should not be venturing into laparoscopy because we have seen a lot of cases with the scar ovarian mets. Peripartum hysterectomy, I think we can be avoided, and stage 3 ovarian cancer should be avoided. Clinical decision making, these are the questions we need to ask ourselves whenever we start endeavor onto our journey of doing any minimally invasive surgery. What is my risk of the event the technique strives to prevent? What is side effect of technique? So if I'm doing something, am I doing justice? Is it indicated? When I do it, am I doing it in the right way so that lateral thermal damage and everything do not happen? So if it happens, how am I going to take technique? So what is my chance of responding? What is the technique's feasibility in my practice and setting? So if something goes wrong, how is my team supporting? How is my GI surgeon going to help me, or urologist going to help me? How is my hospital going to help me? Do we have advanced technology to go about with it? So feasibility is very, very important. What are my values? Am I doing the surgery just because I want to learn, or do the surgery is indicated? Remember all this when we start making clinical decision making. And also remember that 3% are only because of lack of technical thing. 37% is because of the complications are because of visual and perception problems. Because you know something is floating, you know there's something yellow floating, but you do not know that is feces. Then you do not know that there's an injury happened, then you do not go around searching for it. So sources of complication is first is cognitive science, second is systems error, third is equipment issue, fourth is surgeon selection and training. So what do I mean by cognitive science? Visual perception and processing problem. I already told you. You see something floating, you think it is fat where it is a feces. That is what you see, you need to understand. So your eyes will see only what your brain knows. Loss of haptic touch is something which is very, 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 understand there is a partial haptic touch. So you need to learn the partial haptic touch. So haptic touch from the tissue to the instrument, from the instrument to your hand. This is what you need to learn. So poor performance under stress is something which is a norm, which you have to understand. So please do not put a case at the end of it and don't allow people to come and see the surgery till you are master the surgery. So please be confident of yourself and do recurrent repeated surgery so that you master your technique. Lack of situation awareness. Like I told you, there's a bleeder happening, just go and don't jump and burn it, not understanding that ureter is behind it. So hold it, pull it upwards medially, and then only coagulate it. And long-term memory is important. Semantic memory comes from book learned anatomy and instrument function, which is something which we learn. All of us must have learned in our MDs and all. Procedural memory is what I have shown you. That is how to do a surgery. And this is the way, this is the procedure has to be done. Episodic memory is if any particular, during a particular incident, by stepwise separating it, you had a thing, then you can remember, okay, during particular step, I found it difficult, so let me do something. Or during this particular step, when the bleeder was there, this is what has happened for somebody, so I have to be careful and all that. So all these things are something which we need to develop. How do we reduce risk? Knowledge of anatomy. So one thing is what you don't know, you cannot actually reduce the risk. So proper surgery technique, and then comes the sources and surgical instrument. So learn, master the technique, go. Don't think that we are born with everything. So go properly learn the technique, then come back and take the technology into your hand, and you understand the energy sources. If you don't know that little thermal energy can happen, and if you're not being tissue specific, then you're going to end up with a complication. And you cannot see anything compromising with the vision, the outcomes are going to be bad. So how to avoid thermal injury? When you have to cut, use cutting current. Coag current is more dangerous than cutting current. Compression of the heat with the grasper before desiccation reduces the blood flow and lessens the heat sink effect. Pulsing the energy on and off will allow the energy to come back to the source before it takes off again. So allow the tissue to cool, and little thermal damage is less. Putting a cool irrigation fluid will decrease the little thermal damage. Judicious dissection of the structures and separation from the adjacent tissue is very important. Like I said, technique and then technology. Error prevention, we need to understand we are human. Value the procedures. So talk to the people, see that everything is done. Right side has to be done right, left has to be done. She's for TLHBS, then you know. If your patient is for myomectomy, don't end up doing a hysterectomy, and the patient is for fertility, and then you do a hysterectomy, you know what can happen. These such things can happen, especially in the workshops. A timeout should be conducted before any particular surgery. Once the surgery starts, very few available safeguards. So develop a culture where you know who is the boss. Don't allow everybody to tell you, but you be the boss, but listen to everybody. And anesthetists also can be seeing everything. If somebody suggests something, they can be seeing it before we do it. But surgical training is the main important thing. Deliberate practice aimed at specific components of the task is important. Pelvic trainers, simulators, and seeing a lot of videos by masters and going step by step is the way important. Then comes the actual experience. Simulation, you will never get the hang of it. So I still believe it is the pelvic trainer and the wet lab and the actual experience which makes a huge difference. Surgical anatomy perceptual modules are very important for people who really learn from them. Set of video clips like the way I told you about the successive steps of procedure with repetition coming from different surgeries exposes us to variations in anatomy and crucial maneuvers and significantly increases the perceptual and procedural knowledge. So traditionally, we have learned any surgery for 3 years, but some people are well trained in vaginal, some are for abdominal, but anything we can learn with methodical training. That is what we need to understand. Distributed practice is better than mass practice. Get learning at mass and then not going and doing is not the way to do it. Better to learn in the same context. How is your type of setup, and go and learn that. That is the way it has to be learned. Perceptual learning is prevented by sleep deprivation, stress, and fatigue. So be careful about your health. Chronically under stress will lead to glucocorticoid increase, hippocampal neurons, and lead to memory disruption also. Rules are simple. We are not here to vote off the worst surgeon. We are here to vote for a safe surgeon. So please look into it. And to conclude, I would like to say that world of surgery is definitely rapidly changing. So deliberate accumulation of knowledge and experience is essential. Many hours of practice in simulated situations and actual surgery will allow us to become safe surgeons. But future is always now, but future of any technology depends on how well the training is. My success mantra is if you want to change your life, the 6 T's. 6 T's are, first is technique, second is technology, third is the teamwork, fourth is how well your training is, fifth is keep on teaching so that you learn more and more, sixth is your temperament during surgery. Remember that. That goes a long way in being a safe surgeon. So over to you, Geet. I think we're done. Any questions from anyone?
Yes, we'll have, if anyone has any question, they can raise it.
Geet, if there are no questions, there are two things. One, we have one question. Either they did not understand or they understood very well. Yes, we have.
Ma'am, indeed, this was a pleasure to listen to all the techniques and the talk and especially the Anagani technique which you spoke about. There's a question from Monica, I believe. Yeah.
Yes, please.
Hello.
Miss Monica, you can go on, please.
Yes, good afternoon, ma'am. Thanks for a very good lecture. I'm following you for a long time. But my only question is, you talked about pulse technique, 1, 2, 3, stop, and then again. But usually we are made to taught that we should wait, especially while coagulating the uterine artery. We should wait the bubbles to stop in a bipolar.
Yes.
And then with pulse technique, will this happen? Means we are to discontinue our foot pedal?
See, Monica, very good question. See, the difference between charring and desiccation is when the bubbles start receding, not stop. That is the first point. So for that, to achieve that, why is it important? Charring is 400 degrees centigrade and desiccation is 100 to 150 degrees centigrade. The safety level we want 100 to 150. So when the bubbles start shrinking, that is a very good point. Second, pulse technique is to take us to that level. 1, 2, 3, stop. So some amount coagulation. 1, 2, 3, stop. Why is it we are doing it? The wave which starts will be least. See, always remember energy source or the wave goes through the patli gali se jati hai. It's like just like us, like human mind. We want a shortcut. So whenever the least resistance, the energy goes. So resistance increases, energy goes laterally. Lateral thermal damage happens. So the advanced bipolar mein kya rehta hai? What is the differences between the advanced bipolar and the traditional bipolar is one, compression. I will just put it in the simple thing: temperature, compression, temperature, and time. Okay, these are three things, and then cut. Temperature, when I say in the traditional bipolar, if we don't take care, it can go up to 400 degrees centigrade. Whereas in the advanced bipolar, the upper limit is 100 or 150. That's it. You can never cross that degrees. Second thing, very important, is compression. In advanced bipolar, whether it is NC or whether it is what is that, ligashire, the instrument either compresses or it cannot activate it till it is completely compressed. Here we have to compress manually, right? Third, pulse technique, pulses, time. The time taken to achieve the desiccation, that is Dr. Bini.
Very good. I will do it.
Can you meet? Yeah, Dr. Monica, third important point, it's pulse technique. In the advanced bipolar, there is a pulse inherent either in the generator or in the hand instrument, so that till the doesn't come, it's in pulses. So whereas the same technique we need to use with us, 1, 2, 3, stop, 1, 2, 3, stop, the bubbles start developing, and when it starts receding, you stop doing the pulse technique. That is the end point. So pulse technique is for safety. The end point of coagulation is desiccation. I hope you understood the difference.
Yeah. But my next bit of query more, I use Messenger.
Okay, even same messenger, use it the way I tell, then you will know the safety. Okay, now the cut, here we use scissor and cut or harmonics and cut, whereas cut inherent in the advanced bipolar. So with traditional bipolar, we can make it behave like advanced bipolar by using compression ourselves and using pulse technique the way I told you, and that so that we are stopping the temperature from not going beyond 100 to 150. Okay, Monica?
Yeah, ma'am, thanks.
And use it and let me know feedback. Okay?
Sure, ma'am, sure. I think you have some mail or something.
Yeah, Geet, please give Dr. Monica mail ID. Okay,
I'll do that, man. I'll share that.
All right. Ma'am, I'm following you for a pretty long time. From the beginning, now I have done more than 100 TLHs.
Wonderful. Congratulations. Thank you.
All right. Thank you, ma'am.
Any more questions, please?
I think we do not have. The talk was really nice, ma'am. And we are bang on time, just 5 minutes to our dedicated time. I take this opportunity. Good evening, everyone. Once again, good evening, ma'am. On behalf of every participant who has attended this webinar and from Mindray, it's our heartfelt gratitude to Padma Shri Dr. Manjula Anagani for gracing us with your presence and sharing your invaluable insights with us tonight. Dr. Anagani, your profound expertise on total laparoscopic hysterectomy, safe surgical technique has truly enlightened us. Your words have not only inspired, but also challenged us to think beyond conventional boundaries. We are deeply grateful for the wisdom and knowledge you have imparted in us this evening. Thanks a lot once again, ma'am. Thanks for
Thank you.
gracing the occasion, and thanks every delegate participants for joining us and listening to this webinar.
Thank you.
Yeah. Thanks, everyone. Thank you.